So the first session, the first of our talks, is on the assessment of pain in palliative care. I'd just like to welcome you all along and also to thank Jan Collins for her help in putting all this together. The aim of this session is to provide information that will further develop an awareness of the principles and philosophy of palliative care and assist with systematically assessing the nature of pain and the appropriate use of assessment tools. The objectives include being able to list the factors that influence pain perception, including reference to aspects of total pain, to recognise how a patient's pain is affected by their pain threshold and drug tolerance, identify the importance of taking a detailed pain history, to recognise the importance of using assessment tools when recording and documenting pain, to differentiate various types of pain, including somatic, neuropathic and visceral pain, and to recognise some of the common terminology used in describing physical pain. But before we do that, I'd just like to talk a little bit about some of the basic pathophysiology of pain. So when we look at pain problems starting out in the periphery, there's usually a mechanical, thermal or chemical stimulus that's converted to an action potential in the primary afferent nerves. Pressure may be the primary stimulant, as in mechanical trauma, or there may be chemicals that may stimulate the nerve or may actually just sensitize the nerve. So there may be cytokines like bradykinin or histamine, or others like leukotrienes or prostaglandins. Next, you have transmission of the pain, and that occurs via projection to the CNS, processing within the dorsal horn, and then transmission up to the brain. So action potentials of the primary afferent nerves can be inhibited or decreased by membrane stabilizers, including local anesthetics, and then other drugs such as mixilotine, which is an oral equivalent of lignocaine, and then some of the anticonvulsant drugs such as Dilantin, Tegretol and clonazepam. The dorsal horn is a very complicated area in terms of the ongoing transmission of the pain process. There's a release of neurotransmitters and binding of neurotransmitters on cells, and those transmitters include excitatory amino acids, importantly glutamate and aspartate, and others have been described such as fluoride-resistant acid phosphatase and many other peptides, including vasoactive intestinal peptide, somatostatin, and endogenous endorphins. So when there's repetitive transmission from the primary afferent nerve, there may be a number of changes, including enlargement of the receptive field of the peripheral neuron, activation of normally inactive receptors within the dorsal horn, the concept of wind-up of C fibers, which is a phenomenon of progressively increased neuronal response to repeated noxious stimuli, and this can lead to allodynia. Allodynia is where a sensation which is normally not painful then becomes painful. And this term should be differentiated from hyperesthesia, which is the term used when a painful stimulus causes much more heightened pain response than one would normally expect. From the dorsal horn, you have propagation of the message, and that goes up through the ascending pathways, including the spinothalamic tract, the spinoreticulator tract, and the spizo-mesencephalic tract. Probably the most important ones are, however, the spinothalamic tract, and certainly in terms of physically stopping the pain, then it's the spinothalamic tract that's targeted when one gets a percutaneous or open chordotomy done as part of getting pain relief for significant and intractable pain. The Process of modulation includes both enhancement and inhibition of nociceptive stimuli. It's important to remember that there's not only pathways that head caudally, but also pathways that head in the other direction, in particular the descending inhibitory pathways. And this includes the opioid pathways and serotonin and alpha adrenergic pathways, and hence the use of particular drugs, including obviously opioids, but also the tricyclic antidepressant drugs, which have been used to try and help for pain for many decades. Other drugs that are used include clonidine. However, these sorts of drugs are usually used in combination with spinal opioids. So palliative medicine is the study and management of patients with active, progressive, far advanced disease for whom the prognosis is significantly limited, and the focus of care is on symptom management and quality of life. Now, this seems fairly straightforward when you look at this definition, but obviously within that definition there are significant changes that are going on in the patient, and things that you can actually do from time to time to actually help improve the quality of life of the patient that may in fact prolong the life of the patient. And in that situation I'm particularly thinking of patients who may have sepsis and require antibiotics, and that may in fact prolong their life in certain situations. The incidence of cancer-related pain is relatively high. Cancer deaths account for about 25% of the deaths in our community, and pain is experienced by somewhere between 20 and 50% of patients at the time of diagnosis, but then this increases during the course of the illness, and towards the end of the patient's life, those patients with advanced disease, then approximately 75 to 80% of patients will have significant pain, which is defined by the use of opioid drugs. The incidence of cancer pain does vary with the primary site and the site of metastases. So in this slide you can see that esophageal cancer and pancreatic cancer are associated with a high incidence of significant cancer pain, and similarly patients who actually have bone metastases from whatever cause can have a high incidence of pain, particularly if there's significant structural damage to the bone. If you look at lymphomas, however, then the incidence of pain with lymphomas is considerably less, but once again this depends on the site of the disease. Cancer pain varies when one looks at where the patient is actually being looked after, and obviously it varies when you're looking closely at the actual incidence of cancer pain. So unrelieved pain in this setting can occur in up to 14% of hospitalised patients, but the incidence falls quite significantly for patients who are actually in a palliative care environment or inpatient hospice setting. Figures do show a significant difference between the primary care person and the patient in terms of how actively they describe the significance of their pain. Looking specifically at lung and colon cancer, cancer pain does interfere significantly with quality of life. If you look at global life enjoyment, over half the patients have pain that interferes moderately or more than moderately. And similarly, sleep is the other one where pain seems to play up and cause significant issues. And I think this is an important thing to actually ask the patients when they see you in terms of whether the pain actually does interfere with their sleep. Interestingly, walking and social relations doesn't seem to be as big an issue in terms of interference by cancer-related pain. Looking specifically at lung and colon cancer, cancer pain does interfere significantly with quality of life. If you look at global life enjoyment. Over half the patients have pain that interferes moderately or more than moderately. And similarly, sleep is the other one where pain seems to play up and cause significant issues. And I think this is an important thing to actually ask the patients when they see you in terms of whether the pain actually does interfere with their sleep. Interestingly, walking and social relations doesn't seem to be as big an issue in terms of interference by cancer-related pain.